Migraine is episodic, pulsatile, or we can say throbbing headache, which occurs mostly on one side of the head, and it comes in attacks which last for approximately 4 to 72 hours. These attacks may be triggered by certain conditions, for example, bright light or glare, loud sounds, hunger, lack of sleep, alcohol, even hormonal changes in menstrual cycle. And this headache is generally accompanied by some other symptoms like nausea, vomiting, sensitive to light, that is photophobia, sensitive to sound, that is phonophobia, and vertigo. Now, migraine is of two types. One is classical migraine and the other is common migraine. Common migraine is the one where only headache occurs with these other symptoms. So that is migraine without aura, and the other is classical migraine where migraine occurs with aura. Aura is basically accompanying some neurological symptoms which can be either visual, that is they can be flashing light, or they can be auditory, for example ringing in ear. They can be sensory symptoms, for example, sensation of pins and needles. So when this headache, either these aura symptoms, the neurological symptoms either precede the headache or occur with the headache as well. And when the headache is accompanied by these symptoms, that is known as classical migraine, that is migraine with aura. So how this migraine occurs? What is the pathophysiology? Well, there have been two theories describing this. One is the vascular theory and other is the neurogenic theory. So basically in vascular theory, it says that there is dilation of carotid arteriovenous anastomosis. So these anastomosis are not normal. These is abnormal anastomosis are there. So arteries are connected directly to veins in these anastomosis, and if there is abnormal dilation of this carotid AV anastomosis, what will happen? That blood will directly pass from the carotid artery to these veins, and the blood will not go through the branches of the carotid artery, and there will be decrease in blood supply to the brain tissue. This will produce brain ischemia and hence hypoxia, and this is going to elicit pain. So that is vascular theory. According to neurogenic theory, there is release of certain neurotransmitters from neurons, that is CGRP, substance P, okay, and neurokinins. Such neurotransmitters are released and they act on blood vessels, causing vasodilation and also increase in the capillary permeability. So when there is increase in the capillary permeability, basically there is increase in the space between the endothelial cells which are lining the capillary permeability. So there is movement of the fluid along these spaces into the space surrounding the vessels, that is the perivascular space, okay, and hence this is going to lead to edema because the fluid is moving out. It is going to lead to edema, and this leads to stretch. Now this stretch activates the pain nerve endings in the dura, and that leads to headache. Okay, so there is vascular theory, neurogenic theory. We will see the drugs which act by both the mechanisms, that is either they will act here, that is they will decrease the release of CGRP or block the action of CGRP, or there will be drugs which cause vasoconstriction of this arteriovenous anastomosis. Okay, so moving on to severity of migraine. So now when we talk about the severity of migraine, this classification of mild, moderate, severe is given in KDT. However, clinically this classification is not used. There are other classifications which are based on frequency, whether migraine is episodic or chronic. Chronic is basically when the migraine occurs for more than 14 days in a month. Okay, so that is episodic or chronic. It is also based on, another classification is also based on disability, whether the patient is functionally impaired or how much he is impaired. But this classification can be taken as a general guide for starting treatment, like knowing that whether the pain is tolerable or not. For example, if the pain is throbbing, migraine pain is throbbing, but whether it is tolerable, then it will be mild. Then how many attacks are coming per month? If the attacks are more than 2 to 3 attacks per month, then it is severe migraine. And in this kind of migraine, when more attacks are there per month, we need to give prophylactic treatment as well, that we are going to see subsequently, right? Then how long the attack is lasting? If the attack is lasting, say suppose from 12 to 48 hours, then we need to give another dose of the drug as well. Okay, and how much the person is functionally impaired. So for example, if the headache is not incapacitating the individual and the person is able to carry out his day-to-day activities, then certain milder form of treatment will suffice for the treatment. So what are the drugs which are used? Well, before that, first we need to know that what is the approach for treatment of migraine. One is avoidance of patient specific triggers. So we have to elicit the history that what kind of triggers lead to such kind of headache. So we have to counsel the patient for avoiding such triggers, and in many of the patients only this can be very effective. Then we have to treat the acute attack, that whenever the headache starts, we have to give the drug as soon as possible to obviously decrease the pain and also to abort the attack, because if the attack starts, it can last for even 72 hours. So if treatment is given for aborting the attack, but another dose is required within 60 minutes of the first dose. Okay, so the migraine patient, the attack is not subsided and another dose is required within 60 minutes of the first dose. Then it is important that during the next attack when it occurs, increase the dose. In the first dose itself, we have to increase the dose of the drug, or we have to change the drug. So there are drugs which are used for aborting the attack that we are going to see. Then we have to see what is the severity. Obviously, I told that if the attacks are more than 2 to 3 attacks per month, or the headache is unresponsive to drugs. For example, you have given the drug for acute attack, but the headache is not responsive. The headache continues and you have to repeat the dose, because we cannot repeat the doses too often also. So it is important to give prophylactic treatment so that the headache doesn't occur only, right? Then if the headache is causing severe disability in the patient and it is affecting the day-to-day life of the patient, and if it is a severe subtype of migraine, for example, hemiplegic migraine. I'm not going to discuss the different types of migraine, but there are certain types, for example, hemiplegic migraine, or in which the aura is of brainstem symptoms. Okay, so those types of migraines we have to give prophylactic therapy. So what are the drugs which are used? Well, if the pain is of mild variety and it is not functionally incapacitating the patient, then we can give milder drugs, for example, paracetamol, aspirin, or we can also give NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen can be given, which can be repeated in like 3 to 4 hours. And along with ibuprofen, depending on the patient, because the therapy has to be individualized, NSAIDs can also be combined with paracetamol, they can be combined with a sedative, and also with antiemetics. We have seen before that generally migraine is associated with nausea and vomiting. So antiemetics also need to be given. If the headache is of moderate intensity, then paracetamol and aspirin are not effective. So we have to give NSAIDs. If the patient is not responding to NSAIDs, then we have to add other drugs. And these drugs include the triptans. We have seen in our previous video the serotonin agonist which act on 5-HT1B and 1D receptor. Those are the triptans. So triptans and another drugs are ergot preparation. We will see a little bit more about these drugs. But remember that triptans and ergot preparations are the drugs which can be used in moderate and severe variety to abort the attack. Okay, then in severe condition, again paracetamol, aspirin obviously will not be effective. In fact, NSAIDs also are not effective. So for this we give triptans, ergot alkaloids. Combination drugs are available where triptans can be combined with NSAIDs, and prophylaxis has to be given for 6 months. Then what are these triptans? So triptans, as we have seen in the video on serotonin agonist and antagonist, that these triptans are 5-HT1B or 1D receptor agonists. So we have seen that yes, CGRP is released from the neuron terminal, and this CGRP is responsible for causing vasodilation and increasing the permeability, capillary permeability. So this 5-HT1B receptors are basically autoreceptors. Okay, autoreceptors, and autoreceptors mean that when this drug agonist will stimulate this, the decrease in the release of the neurotransmitter is going to occur. Autoreceptors always decrease the release of the neurotransmitters. Okay, so one example of this drug is sumatriptan. So it stimulates this 5-HT1B receptor, decreasing the release of CGRP. So it has to be given at onset of attack, obviously moderate and severe kind of headache. And one advantage is that triptans also decrease the nausea and vomiting which is associated in migraine. So no need to give antiemetic separately. Then sumatriptan is also available in nasal and subcutaneous injectable forms. Okay, and this nasal and the subcutaneous injectable forms can be used if nausea vomiting is there and the person is not able to take the drug orally, and also for rapidly developing symptoms, so that we want the response to occur fast. Okay, but remember the triptans are contraindicated in coronary artery diseases in case of hypertension, because these triptans cause vasoconstriction, especially coronary spasm they cause. Okay, so they are contraindicated in coronary artery diseases. They are also contraindicated in hepatic renal disease, in case of epilepsy, and should not be given in pregnancy. So we have another class of drugs, that is ergot alkaloids, which are also contraindicated in coronary artery disease and also in hepatic renal disease. But these drugs can be used if triptans fail. But remember, these are second tier of drugs. They are not generally used because of the availability of triptans and too many side effects of these drugs. These drugs are not generally used but can be used if triptans fail, and they can be used for very rapidly developing symptoms, because this drug dihydroergotamine, in ergot alkaloids we have ergotamine and dihydroergotamine. This dihydroergotamine can be given by subcutaneous injection, intramuscular injection, and can also be given IV. Okay, so this can be given for very rapidly developing symptoms. And then for menses related headache, this can be given both for prevention as well as for treatment. But remember, sumatriptan and ergotamine should not be administered within 24 hours of each other. For example, you give sumatriptan and the patient doesn't respond. That doesn't mean that you will give ergotamine now. Why? Because they act by same mechanisms, 5-HT1B, 1D agonist. So there is no benefit. In fact, the side effects are going to add up, because this ergotamine also is contraindicated in coronary artery disease. It will also cause coronary vasospasm. Okay. So we have some newer drugs for acute attack. First is 5-HT1F agonist. Well, this is same autoreceptor like 1B and 1D. We did not discuss about this 1F receptor in our serotonin agonist antagonist video, but this is a similar receptor which acts as autoreceptor, and there is a agonist lasmiditan, which stimulates these receptor. It causes decreased release of CGRP just like triptans. However, this has an advantage. There is no direct vasoconstrictor effect on blood vessels. So, this is not contraindicated for coronary artery diseases, because this does not cause coronary vasospasm. But remember that it can cause dizziness. So, that is why when this drug is given, there is restriction of driving. We have to counsel the patient for driving restriction. Then another class of drug is CGRP receptor antagonist. So CGRP is released, but you block the action of CGRP, and these drugs are GPANs. So this CGRP is basically calcitonin gene related peptide. Okay, so this is gene related peptide. Okay, so this GPANs words is coming from this G and P. So, gene peptide antagonist, ANTS is for antagonist, right? So, we have rimegepant and ubrogepant, which can be given orally for acute attack. Then coming to prophylaxis of migraine, we have already seen what is the indication for the prophylaxis of migraine, that it is severe attack and more frequency of attacks, more than 2 to 3 attacks per month, and very debilitating headache is there, and it is not responsive to the drugs which are aborting the attack. So in that case, we have to provide prophylaxis for migraine. So what are these drugs? First is beta blocker, that is the propranolol. Mechanism of action is not known, but it may be that it causes vasoconstriction. Then second is tricyclic antidepressants. and these drugs are mainly preferred in patients of depression with migraine. So these tricyclic antidepressants basically block uptake of serotonin. So they are going to increase the levels of serotonin and norepinephrine in synaptic cleft. And this serotonin actually is a part of descending pain analgesic system. I have a video on pain, separate video where I have dealt about this descending analgesic system, and serotonin is one neurotransmitter which is involved in that pathway. So by increasing the levels of serotonin, there is enhancement, basically increased activation of descending analgesic system. Then we have calcium channel blockers, in which we have flunarizine. Flunarizine is cerebroselective calcium channel blocker. So if calcium channels are blocked, we know that calcium entry is important for fusion of the vesicles to the presynaptic membrane and then the release of the neurotransmitter. So if these calcium channels are blocked, then the fusion of the vesicles will be less and release of the neurotransmitter, that is CGRP, will be less. Okay. So that is third category. Then we have anticonvulsants, and these are used if patient is refractory to other drugs. And what is the mechanism of their action? Well, anticonvulsants, they block the voltage gated sodium channels. So this valproic acid, topiramate block voltage gated sodium channels. Now, one theory for migraine with aura, especially migraine with aura, is cortical spreading depression. What is this cortical spreading depression? What it says is that there is neuronal hyperexcitation. Okay, so all the neurons get excited, and this excitation spreads throughout the neurons in the brain. And after that, there is some silence in the neurons. That means they become less excitable. So that is what it is, depression. Okay. So cortical spreading depression is responsible for migraine with aura. That is one theory. So these anticonvulsants, by blocking the entry of voltage gated sodium channels or by other mechanisms, they decrease the excitability of the neurons itself. So that they are less excitable, so they will not be spreading excitability and then spreading depression. Okay. Then we have another newer classes of drug, that is monoclonal antibody against CGRP receptor. Okay, so we have various drugs like erenumab, galcanezumab, and these drugs can be given by one subcutaneous injection per month, which decrease the frequency of migraine attacks. Then another drug is onabotulinum toxin A. Now this toxin basically is used if it's a chronic migraine. Initially I told you classification of episodic and chronic migraine. Chronic migraine is if headache occurs for more than 14 days per month. In that case, this onabotulinum toxin A is given, which can be given every 12 weeks and is injected around the head and neck. And just like botulinum toxin, which we study in neuromuscular junction, onabotulinum toxin A prevents the fusion of the vesicles with the presynaptic membrane. Okay, so flunarizine, we have seen that calcium entry is not occurring, so vesicles are not fusing. Here, botulinum toxin, how it acts from neuromuscular junction, you can remember that actually here there are certain proteins, that is the snare proteins, and those are destroyed by botulinum toxin. So similarly here, onabotulinum toxin will prevent the fusion of the vesicles with the membrane, thus decreasing the release of the neurotransmitter, that is CGRP. So that was about migraine prophylaxis and treatment. And just like all pharmacology videos, the video notes of this video will also be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.